my presentation, and I thought whether to stick on something very specific, just to discuss with you, about a disease and the biomarker, or giving you an overview of different biomarkers. So I thought that was, let's say, easier for me to give you an example of a disease and the biomarker, something that we are actually working at in the lab. And I will take you through a little bit of this journey, giving you some hints, and ideas about how this development of a biomarker works, at least on the lab side, so on the research side. I hope this is the right thinking to do. So I pick up a very rare, an ultra-rare sarcomas, which is epithelioid hemangioendothelioma, EHE. And this is one of the malignant vascular tumor, together with angiosarcoma. And the main characteristic of this tumor is my pointer is like this, yes. It's like this tumor have two different types of translocation that involve a very common mechanism in cancer, which is YAPTAZ, which is well studied and probably definitely more popular for the work in other diseases such as breast cancer and lung cancer. A lot of researchers spend time on YAPTAZ signaling because of the stiffness of the cell, which could be very relevant. The mechanotransduction, they use this very peculiar words to describe some of the role of YAPTAZ. But generally, these mechanisms, at the end of the day, led to cell growth and proliferation of tumor cells. EHE is a quite a fancy sarcoma, not just because it's super rare, but also because there is this mechanism of oncogenesis, and in the very aggressive form of the disease, this mechanism goes together with others. So the tumor accumulates molecular alterations that make the tumor even more and more aggressive. And maybe someone of you know EHE, maybe not. Just to say that there are very indolent form of the disease. There are some people with a tumor that can stay there for ages with no progression, and other people that can experience a very aggressive form with fast progression, symptoms that do not respond nicely to systemic treatment. So it could be very difficult. And there's no approved treatment at the moment. Medical oncologists, particularly people from our institutions, from the National Cancer Institute in Milan and also from the Marsden, spend time working on the effect of sirolimus, because it seems that it's more effective than the first-line treatment doxorubicin. They're also putting a lot of efforts going through EMA application for repurposing. So this day, even though this disease is very rare, is becoming popular for the research side, and because also of the involvement of the patient association, which is helping a lot in the process of the repurposing. So we did this work in the lab in parallel with the clinical work, and our idea was to work on circulating cytokines. Cytokines are proteins that flow in the blood, and we specifically look at them. We are also looking at hormones and miRNAs, but today we'll talk with you just about circulating cytokines. And we want the idea was to identify a biomarker that help in patient management at the level of patient risk stratification, which means prognostic factor, basically, then prediction of response, and hopefully also therapeutic targets. So these are the three main things, and this is just my methodological point, that explain why biomarkers is useful. So stratification, prognostic stratification, predicting response to drug, and being a therapeutic target itself. So if a biomarker has all these three aspects, it becomes particularly interesting. And this is the kind of work we are conducting, and that I was mentioning you before, with the inflammatory cytokine, the circulating microRNAs, the hormone profile, because this tumor is occur mainly in women, and the whole idea is is to look at disease aggressiveness and response to treatment. We were lucky enough, being a reference center in Italia, to work out a retrospective series of patients that came to see our medical oncologist over time, and thanks to their help, to start a prospective observational study at our institution, and also in parallel with people at Royal Marsden and ICR in London. So this is how it works in the very beginning of the study. It is important to have a cohort of patients that are healthy donors, so means people that, you know, come to the hospital to donate their blood, so they are not cancer patients, all right? So they are, let's say, normal people from the lab perspective, this is how we say. And then we classify EHE patients in two groups based on the evolution of the disease, mainly, in a lower risk group and in a higher risk group. So we came out with 3 different groups of people, right? One without disease, one with disease but a low risk, and one with disease but a high risk. And we use a couple of laboratory tools to look at cytokine that might be altered, you know, and modified across these different patients. One is a qualitative one, which means that give us just the idea, the cytokine array give us just the idea that a cytokine is different between these groups, and the other one is more quantitative. So it gives us a number, a concentration of a specific cytokine across the patient groups. And we were quite surprised, because among about 100 cytokines we look at, we came up with this GDF15 being the most interesting one. I will be back in a sec on what GDF15 is. And these graphs show, you know, 3 types of analysis. One on the retrospective study that I showed you before, the retrospective patient. One of the prospective cohort of the clinical trial, observational trial that is ongoing in our institution. And then we also combine them just to give more statistical power. And you can see quite clearly that patients with high risk disease had much more GDF15 circulating in their blood, compared both to patients with lower risk disease and also to lower risk disease, and also to healthy donor. And these results were very similar, right? Almost superimposable between the two cohorts. And this is also another important point. So biomarker, in order to be relevant, needs to be reproducible across different series of patients. And this is the first step. The second step is to make it reproducible across different institutions, across different labs, and so on. But this is the first important step to establish a biomarker. Just to say something about GDF15, because I think it's becoming more popular in oncology these days. The main thing is that because quite recently it has been discovered that GDF15 is responsible for the cancer-related cachexia, because the only receptor, so the only molecule able to catch GDF15 that we know at the moment, is located in the brain, in the area where the cachexia, in the area that is responsible for cachexia. Another important point is the immune modulation effect of GDF15. For instance, in other diseases such as urological malignancies, they realized that patients who were not responding to immunotherapy, right, had high level of GDF15, not circulating GDF15, but in the tumor this time. And so they use a drug to target GDF15, right? And the effect of immunotherapy was higher. And this was a phase 1 study, and there's an ongoing phase 2 study now. So it's an interesting immune modulator. And then high level of GDF15 correlated with disease progression, with metastasis at the end. And we know that also in sarcomas, in studies on osteosarcomas, for instance, and also in uterine leiomyosarcomas. So we have few data also in sarcomas, and this is how our data on these very rare sarcomas, vascular sarcomas, EHE, are relevant. We were lucky enough, that so better to say that the next step for us would have been to understand whether GDF15 was produced by tumor cells or was produced by other cells in our body. And this is very relevant because it allows us to understand whether the production of GDF15 is tumor specific or not, right? Because also other cells of the human body contribute to the pool of circulating GDF15. And we were lucky enough to generate a patient-derived models, so a tumor that grow in mice and that also grow at cell lines. And in these tumors, right, which were derived from a patient with a very severe EHE, we were able to conduct some experiments to understand whether actually the tumor cell produced GDF15. And this part is about the cell lines that I showed you before, and this is about the PDX, which is the immunocompromised mice with the human tumor growing in, all right? And so we realized that compared to other sarcomas, you might recognize the acronym, so to pleomorphic liposarcoma or the diff liposarcomas, cell lines from EHE have actually higher level, definitely higher level of GDF15. And the same apply to mice, because mice with EHE have high level of GDF15, and these are not there in healthy mice, so mice without tumor, or mice with other diseases. Here, again, I reported the liposarcoma, but also in mice with other sarcomas, we don't find the GDF15. So what we did then, I mentioned at the beginning the sirolimus and the effect of sirolimus on EHE. And this graph, this one is on cell lines and this one is on PDXs, and they basically both describe the same phenomenon. So probably this is the easier one to understand. So these are the days of treatment in the days of the mice and the treatment, and this is the volume of the tumor. You can see that the control, so the untreated tumor grow, and the tumor treated with doxorubicin grows similarly to the control. The situation is completely different with sirolimus, which here has been used at different dosage for several reasons we can talk about. So we use these experiments both in cell line and PDX to see whether the sirolimus was able to change the concentration of GDF15, and importantly to reduce them, because this is how a biomarker could become relevant also to monitor the response to treatment. So a prognostic and a prognostic biomarker becomes also a predictive biomarker. And actually, sirolimus was able to modulate the GDF15 concentration. You can see here, this is the control, in black the untreated tumor, in blue the tumor treated with sirolimus, so the GDF15 level is lower than the control, and the tumors treated with doxorubicin, the standard treatment. And the same, pretty much the same happen in PDX. So we demonstrate that sirolimus was able to modulate GDF15, which means that if we want to know whether a patient is responding to GDF15, to sirolimus, before waiting the CT scan to come, we can measure the baseline GDF15 and the GDF15 after the start of treatment. And we also work out to a mechanism how this happens through some transcription factor, but I don't want to get into too many details. Just to close, I want to give you two examples because the study is ongoing. Two examples of two different patients. The one on top is a patient with a high-risk disease, so quite an aggressive tumor progressing. These are the scans of the patient. These are the levels of the GDF15. So basically what happens, from here and here, the patient progressed. The tumor of the patient progressed. Then the patient was started on sirolimus, and there was a decrease of GDF15 consisting with the treatment with sirolimus. Eventually, the patient relapsed, and there was an increase in the GDF15 level before that was possible to detect before the CT scan. And this is another point where a biomarker is useful, so to detect a recurrence or a tumor progression or the not effectiveness of a drug ahead of a CT scan. Oh, sorry. And the other example is much easier because this was a low-risk patient with a low level of GDF15 that remained stable over time, and also the CT scan was the same, and the patient felt exactly the same with no new symptoms or other issues. So I hope I give you, with this talk, some ideas about a biomarker in a specific disease. Definitely what we did show that this GDF15 is quite promising as a biomarker for risk stratification, and we put together also some data about the possible use of GDF15 to monitor treatment in EHE patients, and there's still work to do to further develop this biomarker. And I want to conclude thanking the people at our institution who collaborate with, particularly people from our lab and the clinicians who support us, and the medical oncologists who conducted the clinical trials, and the collaborators in London. This work has been done also with the collaboration of the two HE Foundation, one in the UK and another one in the US, and also with the support of our institution and IRC. Also within the Sarcoma Accelerator Consortium, which we created a few years ago and is now paying off. And thank you for your attention.
Thank you very much for that presentation and helping us understand the process of kind of the development and the potential impact of biomarkers. And now we turn to Dr. Ermine Hapatoglou, and she, as many of you heard her speak this morning, but just as a reminder, she's a clinical research fellow at the Royal Marsden University College London, and she has research interests in immunology and cancer cell biology, and she's going to give us an update, medical update and clinical trials update in soft tissue sarcoma. Thank you. Perhaps while we're waiting, if there are some questions from Dr. Pasquale's talk, you could certainly entertain them now. Yes, please, here, let me.
Okay, simple question. Are you working in other biomarkers for other sarcomas or not?
You mean other sarcomas with the GDF15?
No.
Other biomarkers in general? So the answer is yes. And we are working on multiple biomarkers at the moment. The other one we are spending some time with are the microRNA, which are small fragments of RNA circulating in human body, and they can both contribute it by tumors or by normal cells. And it's often difficult to understand the border between, sorry, probably it's better for me to stay here, yeah. It's kind of difficult to understand the border between which microRNA are contributed by, the tumor or the normal cells. So when we do an analysis of microRNA, we come out with hundreds of different microRNA, and we use exactly the same system of the healthy donor and different disease types and different, I mean, disease type, I mean in terms of classification of the disease aggressiveness to understand better a biomarker. And there are quite nice analysis that is possible to do. And we are working to this on different sarcoma. Another thing we are working at is the circulating tumor DNA, which is probably, would you mean to finish answer the question or to answer later?
Go ahead, please.
I finish. The ctDNA, this is again from patient blood, and this is a biomarker that is better established and also used in different cancer types such as lung cancer, and there are some results, some interesting results in GIST. They probably talk about this in the other track that we were mentioning. And also we do some immunomonitoring, so the changes in immune cell population during the course of the disease. But this is a bit more experimental and has less clinical implication, but it's nice to understand the biology of the disease.
Okay, thank you very much.
I would say this.
And what about the extracellular vesicles?
Yeah, we are also working on extracellular vesicle, but so extracellular vesicles are very interesting, and they are another part of the liquid biopsy, let's say. When we think to liquid biopsy, we should think to circulating nucleic acid, that means DNA and RNA, microRNA, extracellular vesicles, and then many others, but less commonly studied. At this stage, extracellular vesicles are very interesting at the lab level to study the biology of a disease, but in clinically wise, they are much more difficult to implement because there are a lot of methodologies to study extracellular vesicles, but the most appropriate ones are very time consuming and are quite far from the clinical work.
Okay, thank you very much.
Thank you, Dr. Habab.
Hello again. So this afternoon I'll be talking to you about some recent advances in medical oncology for soft tissue sarcomas. It's not advancing. Now it's working, yeah. So as we know, the sarcomas we have two main groups in sarcomas, soft tissue sarcomas and bone sarcomas, and we have many different subtypes of soft tissue sarcomas. And the treatment options available for different subtypes of sarcoma is quite variable, and the same is true for the clinical trials that are up and running for different types of or subtypes of soft tissue sarcomas. Before I start talking about the actual treatments, I just wanted to share this with everyone, which I saw in the Sarcoma UK website a while ago. It says the loneliest cancer, sarcoma. I thought it just says a lot on its own. It kind of, in a way, summarizes a lot of the issues we have in terms of treatment options for sarcoma. It is definitely an unmet clinical need, unfortunately, for some patients with poor prognosis, and there is definitely a lot of need for more research, new therapies, and better outcomes. And hopefully I can highlight some of the better outcomes with my upcoming slides. So in terms of therapies for sarcoma, the treatment of this kind of summarizes a lot of the treatments that we have available for different types of sarcoma. And as you can see, different drugs that we have available target different mechanisms of action that lead to different pathways, rather, that leads to development of sarcomas. So we have the drugs that target angiogenesis, meaning blood vessel formation, that supply the blood to the tumor and make it more aggressive. We have treatments that target the cell cycle progression, meaning division of the cells, which happens in an excessive way when you have a cancer. epigenetics pathways, which regulates gene expression, and also the tumor microenvironment, so the immune cells. So I would like to start initially with talking about the targeted therapies, the update on targeted therapies in soft tissue sarcomas. I did not realize that there's a separate GIST section, so I will just skip my GIST slides and go to the other treatments. There's quite a few slides, sorry. So we have already briefly talked about the NTRK mutations or fusions rather, and treatments that are available to target them. So what is a TRK? So it stands for a tropomyosin receptor kinase, which is a complicated name for a protein that is actually expressed in healthy tissue. So it's expressed in human neuronal tissue, but when it goes through a mutation, a fusion, it kind of changes its function, and it then leads to cell proliferation, which then causes cancer. And we see this in soft tissue cancers, but we also see it in different types of cancers which are not sarcomas, such as some of the gastrointestinal cancers and many other tumor types, which I will talk about in a minute. So there was a phase 2 clinical trial which looked at using a drug called larotrectinib, which targets the TRK fusion in patients, in adult and child patients with different types of cancer. So they had 55 patients overall, and there was a big age range, so they had patients from 4 months old to 76 years old with cancers that had TRK fusions. When you look at the results, it's very impressive. So what you see going upwards is the increase in the size of the tumor, and what you see going downwards is the reduction in the size of the tumor. And quite impressively, a lot of the tumors have reduced in size quite significantly. And if you look at the different colors, they each represent a different tumor type. So there were patients with thyroid cancer, colon cancer, melanoma, lung cancer, and soft tissue sarcomas in this trial. And the overall response rate was 75%, which is very, very impressive for a soft tissue sarcoma, or for any cancer really. And the median time to response was 1.8 months, meaning that they started seeing response in patients about 1.8 months after giving them treatment. And if you look at the graph, some of the patients had kind of ongoing response quite a few months later. The median progression-free survival was not reached because they continued to respond, and at 1 year, 71% of the responses were ongoing, which shows that not only the tumors have shrunk in size, the patients also continue to have a durable response, which is an important factor in any kind of therapy you develop. And then they specifically looked at the sarcoma patients in this trial, and you can see here that they had patients with different types of soft tissue sarcomas, patients with GIST, patients with bone sarcomas, and also the pediatric patients with infantile fibrosarcoma. And most of the patients had a response. They had a reduction in their tumor, which is very impressive. So in summary, there was a good duration of response, good progression-free survival, and overall survival as response to this treatment. I'd like to give you an example, a case study from our institution at the Royal Marsden, a 51-year-old gentleman who had metastatic spindle cell sarcoma arising from the prostate. He had a tract fusion. So he was initially treated with radiotherapy, then had developed metastases in his lungs and had further progression, was treated with radiotherapy, then chemotherapy, unfortunately had further disease progression, and at that point we had the larotrectinib available, and he was treated in September 2021. And on the right, I think on your left rather, the lung, you can see his tumor when he first started the larotrectinib treatment, and 5 months later the tumor is quite, the metastases in the lung is quite significantly smaller. And this is, he had multiple lesions, and you can see it in all the lesions he had in his lungs. So I think, you know, it's quite nice when you see someone who gets benefit from a treatment. And I think the key in this is that, you know, there was a specific mutation that was identified, and the treatment was kind of designed in an intelligent way to address a specific problem that we knew was driving the cancer. And I think that's an important concept in developing new therapies for sarcomas and other cancers. Now I'd like to move on to another subtumor type, epithelioid sarcoma, which is a very rare and aggressive soft tissue sarcoma. We know that about 90% of these tumors have lost INI1 expression, and then as a result of this, they become dependent on AZH2, which is involved in histone methylation, which is basically an epigenetic pathway. And studies have shown that this INI1 loss is seen in other types of sarcoma, such as epithelioid, peripheral nerve sheath tumors, myoepithelioid sarcomas, polydifferentiated chordomas. Well, it's mainly seen in epithelioid sarcoma. So there was a clinical trial, a phase 2 clinical trial, which used an agent, a drug that targeted this AZH2. So they had 62 patients in this trial with either locally advanced or metastatic disease who had the INI1 loss, and these patients were given the tazemetostat treatment, and they then looked at the response. You can see that for a sarcoma that has a very poor prognosis, the median progression survival was 23.7 weeks. I mean, it's not great, but it's still better than the standard of care options. And what's even more interesting in this was that, so they had locally advanced patients with locally advanced disease who didn't have any previous chemotherapy, and they also had patients who had previous lines of treatment. And actually the cohort who did not have any previous chemotherapy or radiotherapy had a better outcome in terms of progression-free survival compared to the patients who did have prior treatment. So in summary, they have seen a good clinical activity with this agent in this group of patients, and there is now a clinical trial running with this treatment in combination with doxorubicin, which is a chemotherapy in the first-line setting, meaning in patients who have not had any previous treatment. Now moving on to immunotherapy, which has been a hot topic in cancer for the past few years, and it is also an area of interest for me. So I'd like to talk about the SARC-28 study. I don't know if some of you might have heard about this. So immunotherapy has revolutionized treatment in many cancers and changed outcomes, including in melanoma, in lung cancer, in kidney cancer. But unfortunately, we haven't really seen that success in sarcoma yet. So in the SARC-28 study, they have used pembrolizumab, which is an immunotherapy that doesn't work on the cancer cells, but works on the immune cells to activate them so that they can go and target the cancer cells in the body. And in terms of the patient cohort, patients with locally advanced disease, which were not resectable, or metastatic disease were involved, and they had both soft tissue sarcoma patients and bone sarcoma patients. In terms of the number of patients, it was a relatively small study because they had about 42 patients in each group. Despite the excitement around the study, unfortunately, the results were quite disappointing. As you can see, most of the patients actually progressed. If we focus on the soft tissue sarcoma group, the undifferentiated pleomorphic sarcoma patients and the liposarcoma patients had some stable disease and some partial response, which was kind of a more positive outcome within a negative study. And here you can see this is just again showing the change in the tumor size. Most of the patients had an increase in the size of their tumor, and the ones that had a reduction were the patients with undifferentiated pleomorphic sarcoma. And what's interesting is that although most of the patients didn't respond, the ones that had responded had a durable response, which I think is an important finding. And when they looked at the progression-free survival in soft tissue sarcomas, there was a big difference in different subgroups. So in red, if you look at pleomorphic sarcoma, they had a median progression-free survival of 30 weeks. I mean, in reality, it's a really bad outcome, but if you compare it to synovial sarcoma, which was 7 weeks, there was still a quite drastic difference between the two different subtypes. So there must be something in the biology of these different cancers that makes one of them more responsive to immunotherapy and some of them are completely resistant. Although it was a negative trial, what was important was the translational study that was done on the samples. So for the patients who had either stable disease or the subgroups, the undifferentiated pleomorphic sarcoma and dedifferentiated liposarcoma patients, which were kind of the more responsive subcohort in the study, they have looked at the immune microenvironment in their tumor to see if we can understand why some of these patients have responded and why some of them haven't. So they looked at the immune cells. They looked at whether those tumors had any immune cell infiltration. Then they looked at the characteristics of these immune cells. They looked at the expression of the PD-L1 protein, which is a protein that you can target with immunotherapy. And they've seen that patients who had a response had higher expression of PD-L1 compared to the patients who didn't respond. And then they also looked at functional characteristics of the immune cells that were infiltrating the tumor to see if there was any difference between the responders and non-responders. I won't go into technical terms, but what they've seen is that in the patients, in the tumors that were responding to immunotherapy, the immune cells had a more active phenotype where they were able to kind of do their function properly and get activated with immunotherapy and go and target the cancer, as opposed to being more exhausted or dysfunctional. So I think this is an important finding which maybe can be used in terms of stratifying patients to treatment, understanding which patients, if we look at their tumor and immune infiltration in the tumor, to decide whether, if we give this patient immunotherapy, would they actually respond or not. Another important or very exciting area in cancer has been the cell therapy treatments. And I'd like to give you a quick update on that before I finish. So cell therapy is quite a new concept. It's different to the immunotherapy drugs that we call checkpoint inhibitors, in the sense that checkpoint inhibitors like the pembrolizumab we've just talked about are drugs that we use to activate the immune system. The concept of cell therapy that I will be talking about now works in a different way, that the patient's immune cells are collected from the patient, taken to the lab, they're engineered so that they can learn how to target a specific or attack a specific target in a tumor cell to kind of achieve a more effective outcome. So one of the interesting cell therapy trials has been in synovial sarcoma, which is an aggressive and rare type of sarcoma, which makes about 5% of soft tissue sarcomas. It usually happens in patients under the age of 40 and is usually treated with standard chemotherapy agents that we use for sarcoma, such as ifosfamide, trabectedin, and unfortunately has a poor 5-year overall survival rate. Sandra D'Angelo and her colleagues have run a clinical trial to target the NYSO protein, which we know is expressed in synovial sarcoma tumors. What they've done is they've identified patients who have NYSO expression in their tumor. They have collected their blood and isolated the immune cells from the blood, and taken those immune cells to the lab to engineer them to kind of recognize this protein that's expressed in the tumor. It was a small study. They only had 10 patients that in the end they could evaluate, and their patients have all had at least 2 lines of prior chemotherapy, so they were quite heavily pre-treated patients. But the results were quite encouraging. So about 50% of the patients had anti-tumor response. The median progression-free survival was 15 weeks, and the median duration of response was 30.9 weeks. And in some of the patients, they still had an ongoing response 3 months later. And this is a case study from the trial. So this one patient that participated in the trial, you can see at baseline, so they had lung metastases in addition to their primary. And 2 days later, they had this flare-up of the cancer in the lungs. But 4 weeks later, when you look at the patient, actually the metastases in the lungs and all this miliary disease that was disseminated in the lungs have almost completely gone. And 3 months later, it completely disappeared. And at 9 months, this patient had a complete response that was ongoing. So this is one case out of 10, and some of the patients did progress. But I think this is an important proof of concept that shows if you kind of design the study and you choose your patients correctly, you can achieve impressive, durable responses. And again, they looked at the blood sample from these patients to see if there was anything different between the responders and non-responders. They specifically looked at the characteristics of the immune cells, and they've seen that patients who had a better response had a specific phenotype of T cells which were kind of more active or more experienced rather than being naive. They also had higher IL-15 in their blood prior to starting treatment. IL-15 is a molecule that's kind of involved in regulating the immune cells. So we've actually treated a patient at the Marsden as part of this trial. It was a 36-year-old female with myxoid liposarcoma, was previously treated with radiotherapy, participated in a trial, had progressive disease, then was treated with trabectedin, progressed on trabectedin, and has then participated in this study with engineered T cells. So, I mean, the cell therapy is very interesting, but it's actually quite, it doesn't come without complications. You can get different side effects, especially in the first stage when you're actively receiving the engineered immune cells. So this patient was treated in April 2022, had a quite significant reaction to the treatment and ended up in intensive care, but, improved afterwards, and had a quite good partial response, meaning although the cancer didn't completely disappear, she had a good reduction in her cancer, and has ongoing response actually, which is quite impressive. And finally, I'd like to talk about another cell therapy trial, which just published an updated result. So SPEARHEAD-1 is another cell therapy trial in soft tissue sarcomas. This time, rather than targeting the NYSO protein, they are targeting the MAGE-A4. They've used exactly the same technique. They've identified patients who express this protein in their tumors. They've isolated their T cells, engineered the T cells, and infused them back to the patient. So the response, this is the initial paper that they published with the initial preliminary results. So the treatment is called afimesal, and the subgroup of sarcoma patients they had was synovial sarcoma patients, and the response rate was 36.8%. And they had a good duration of response for up to 50 weeks. And a few days ago, they've just published an update to basically show that a subgroup of the patients still have ongoing response, and they're up to 176 weeks after the infusion. There is still, this is not the entire result for the trial yet. This is just one arm of the trial. They've got other arms, so these patients that I'm talking about, they had only one infusion, just one treatment. In other arms of the trial, the patients are having repeated infusions, and the outcome for that is still awaited. And this just shows the overall survival until now. It's approaching 44 months, and the final results we still yet to hear. This is actually currently undergoing review for approval by the FDA. I think we will find out within the next few months whether this will become standard of care for the sarcoma patients. So in summary, we have new therapies that are making a difference with a better understanding of the biology of the disease, with kind of more targeted treatments. In terms of immunotherapy, I think we are still behind compared to other cancers. I think the main reason for that is we do not have a very good understanding of the immune microenvironment in sarcomas. We've been recycling what's been learned from other cancers and trying to use it in sarcoma rather than having an in-depth understanding of the sarcoma immunology. And I think this is an area that needs more research, more funding. But these new cell therapy trials, I think, quite exciting, and hopefully it will open a door to a new era, I hope, for sarcomas. And that's the end. I'd like to thank Robin and everyone in the sarcoma unit at the Royal Marsden, and thank you for listening.
Thank you, Dr. Papadoglou, for giving us an update on where things stand in the clinical trials and medical update for soft tissue sarcoma treatment. And Dr. Sanfilippo has joined us. She's a medical oncologist. Her research interests are in clinical and translational research, and a particular interest in uterine leiomyosarcoma. And she is at the Istituto Nazionale del Tumore in Milano as well. And so she's joining us for this panel discussion, and we open it now for your questions that you have regarding kind of the scope of where things are at, from laboratory developments, biomarkers, clinical trials, future directions. What are your questions?
You have mentioned T-cell therapy, which is a little bit aggressive from the side effect perspective. If possible, I would like to know if there are some improvements, because patients should go to lymphodepletion, and so it's, I don't know if there are new type of cell therapies less aggressive than we have now.
I mean, the whole cell therapy treatment concept is very new. I think the short answer is no, because we're still trying to understand or familiarize ourselves with the side effects from the cell therapy. But actually, what I was talking about, and the reason why that patient went into intensive care, it's like your immune system gets flared up for a short period of time, and we can manage it quite effectively. It's just, it can be a stressful few days for the patient, but it's not something that lasts for a long time. In terms of the whole process, yes, it's not the same thing as going to a daycare and having an infusion of your treatment and going home. You have to be an inpatient for close observation. Not all patients have what we call a cytokine release syndrome, which is basically overactive immune system, but a lot of patients do. We don't really have anything to kind of prevent that at the moment, but again, it's still at the baby stages.
And yes, it was a very complicated study. I think you agree about that. And the problem is that the company stopped development of the drug in the end because of it was very, very hard, and the cost of the study was very high.
Sorry, I do agree with that. So for melanoma, it got approved recently, not in the UK, but in the US. The cost of the drug, I think, per patient is about $500,000. So when you spend $500,000 on something, and if you're not sure if you're gonna get complete response, that's a questionable treatment. But I think here, what I'm trying to emphasize is the concept. you know, as a concept, I think is quite interesting and important. And, you know, there's a lot of room for improvement, that's for sure.
Maybe we can follow up on that a little bit. When we feel that there's such a desperate need for new treatments, right? I mean, there's so many subtypes for which we still, you know, are not achieving results that we would like to see. And yet then we see development of things that, you know, are very toxic or maybe very expensive once approved. And, you know, how do you kind of balance that as you know, clinicians, researchers, as you're developing things to try to balance this need and want to find new and better treatments, and yet that concern that it may be very toxic or very expensive?
I think the problem to balance is even not only about cost and toxicity, is even about effectiveness of the drug. And I think that in soft tissue sarcoma, we have this big challenge that is totally different from the other cancer. For example, all you know, the success of immunotherapy in melanoma, the target therapy in lung cancer. The problem in soft tissue sarcoma is that the effectiveness, the efficacy of the target therapy are not so high that in other type of cancer. Look, for example, the recent trial of MDM2 in liposarcoma. We have the target because we have the amplification of MDM2. We have the drug because we have a target therapy that is going through the MDM2, but in the end, we don't have so striking result. Recently was presented the result of the study of MDM2 milademetan versus trabectedin, and the two curves were superimposable, like a non-target therapy. So I think that the problem is more complex because you have to balance even the activity of the drug. You can spend a lot of money, you can accept toxicity, but you should have on the other side some activity of the drug. And the problem, the issue is that in soft tissue sarcoma it's very hard to find a biomarker which is a real target for treatment. I don't know if Sandro or you all agree about that.
My comment on this is that it's becoming even more important these days, the use of those companion diagnostics, as they call them. So some biomarkers that restrict populations, patient population on a specific targeted drugs. And these are very difficult to implement. Not very difficult, but they are challenging to implement because a proper companion diagnostic could be found at the end of a study. So at the end of the study, you can realize whether there's something that identified the population with the higher chance of responding. So probably in that population, the cost, as Roberta and Emin mentioned, the costs are worth because the effectiveness is high, and you can even accept a certain amount of adverse event. There are also now there are a growing amount of call for research grants that ask to work specifically on companion diagnostic. The thing that is challenging, and maybe patient could help, is that often trials are run by company which are not really keen to share data and tumors and information, right? Just the tazemetostat study is an example. The study that she showed before was published in 2020, so 4 years ago. So the clinical results, but the correlative science, the association between the molecular profile of the tumors and the response has not been published at all. And the drug has been moved to a different company or a different. So the story is complicated, and I don't know it in details, but the lack of that information is very relevant because it prevents us to find a companion diagnostic. Let's say that only 15 of the patient benefit from the drug, but probably those patients could be identified with a proper effort in the lab to identify biomarkers, working with patient samples, with cells, with PDXs, and they have the patient samples, we have cells and PDXs, so this could be a collaborative effort, and I think we can get there to find the biomarker, but there are barriers that prevent this in the willingness of the companies to share this information and allow researchers, to get into them. And I think this is a bad barrier. And I think that probably patient groups, advocates, and patients can help more than what we can do from our side.
And we've been talking about that today, about how we can work together and engaging across, where are these opportunities and where are the concerns, and people talk about wanting to get together and have these conversations, and these are real examples that are really kind of important to take forward. You talk about that you have the MDM2 amplification, you do this study, and then you don't see that it's any better than what the treatment was already. And I think sometimes we naively think, oh, it's just a matter of what's that, what's wrong? What, and can we target it? And, I think that, can you talk to that a bit and help us understand?
Well, it's $1 million question. We don't know. We don't know. Of course, we have a subgroup of patients that have a benefit from MDM2 inhibition, but the problem is that we don't know who they are. Oh, that's the problem. So it was very disappointed to present this result during the last CITOS, because the development of MDM2 inhibitors takes decades in soft tissue sarcoma community, because it's like a model, it's like in GIST, the mutation of KIT. So now we still don't know. We don't know because probably there are other driver mutation inside the liposarcoma, and Dr. Pasquale is working a lot on that to better understand if when the differentiated liposarcoma progress, other kind of genes are implicated in the progression of the disease. So maybe to stop the activity of MDM2 is not enough to obtain the regression of the tumor. At the same time, we have other situations where you have the drug, for example, but and you have the disease where to use it, but you don't have the possibility to give the drug. For example, it's like sirolimus in hemangioendothelioma. That's what Dr. Pasquale showed before. We know that it is active, but we are not able to prescribe it. It's off-label. That's why, as Italian Sarcoma Group, we are trying to promote a repurposing of some drugs that are still approved for other kind of disease, but are not available for other orphan disease, like EHE, for example. So there are a lot of different situations. Sometimes you have the drug and the target doesn't work. Sometimes you don't have, you know that the drug exists, it is active, but you don't have the possibility to give it because the company are not interested to take and to gather data in such rare disease. It's the same for larotrectinib, no, not for larotrectinib, sorry, for in the inflammatory like crizotinib, for example, in the inflammatory myofibroblastic inflammatory tumor, the drug is active and the drug is approved for other cancer, but we don't have the possibility to prescribe it to our patients. I have 1 million of this kind of examples, so that's why we should work together with the patients advocacy group to implement this kind of to ameliorate to this kind of situation.
Yeah, I think there's clearly interest, right? And it's just understanding how we actually do it, the logistics of coming together. What are some of the top areas that need to be addressed and maybe pick off a few, right? And show success at working together to do it, right? Other questions? Dr. Pasquale, you had mentioned that in your study with the EHE, and it looks like that very nice story of how it was developed and the biomarker and your results. Are we at a point that that's clinically something that should be used at this point in time?
Yeah, this is another interesting part of the story, something that I learned in the process as well. So the test, I mentioned the qualitative and the quantitative assessment of a biomarker, and particularly the GDF15. So the quantitative assessment, that is a concentration, like, you know, like the normal blood test that you see, like creatinine or just a number, a concentration, is relatively straightforward to do because it was, we call an ELISA test. That's the name of the test. And it's a test that is commercially available. It requires a bit of expertise, but even not that much expertise to do it, and is quick to do. The thing is that in order to be approved, it's not enough to perform the test in a research lab, but it should be done in a diagnostic lab, which means a lab with specific certifications from let's say, different stakeholders, depending on the country where the lab is, that allow the test to be diagnostic. For instance, in the US, they call it CLIA lab. In Europe, it's very different across countries. For instance, in Italia, they are region-based. So every region, there are 20 regions in one country, in Italia. Every region has its own certification for the lab, and those are not recognized outside Italia. Okay, so the test should be done in a study in a lab with specific certification. To gain approval, I understood that the best way is to do it in the US in a CLIA lab. So it would be interesting to have a CLIA lab to do the test. Then it's very competitive when you do so, because, for instance, the GDF15 has been used for the predictive value on an MDM2 inhibitor, right, from another company. So not in EHE, but in liposarcoma and in thymal sarcoma, which is another MDM2 amplified tumor, right, just to make things even more complicated. And the response to MDM2 inhibitor goes together with an increase of GDF15 for some molecular reason, which are complicated. I don't get into details. But this tool for the lab assessment is done by Pfizer within the trial. So there's already some company that do the test, but they use them only in clinical trial for their own interest, which in this case is MDM2, in another case is a GDF15 inhibitor, in another case is a TEAD inhibitor. So it's also then another point. It's very complicated to engage with companies that already have some resources for us, for our patients, but actually they don't want to share them for their commercial reason, which are difficult to get, and it's very difficult to speak with them, to find the right person in the company, to engage properly. So I think that this is another very relevant point for this community to come together with, you know, physicians and researchers and you, because they don't listen us. I'm sure you can have more. You can reach more relevant results that we can do. This is our impression. Also, when I speak about this with medical oncologists at different levels, we all pretty much come on this same conclusion. I don't know if you want to add something on this.
Maybe one last question. Similarly, NTRAC, I mean, is that now, should we be doing testing I mean, you showed a number of soft tissue sarcomas. Is that something that should be commonly done, or is that still something that's in a clinical
We
trial
do. So
space?
at the Marsden, so all our patients get, I mean, not only sarcoma, but actually GI cancers, other other subtypes as well. They do get, we do molecular panel, which includes the track fusion as well. Obviously, we don't prescribe it as first-line treatment, but so as an institution, we would like to get all the molecular information that we can for our patients. So it's part of the screening or the molecular panel. I don't know how it is in Italy.
Yeah, regarding NTRK, there is the problem of the rarity of this mutation because it can be across different histotype, but in the end, we are learning that maybe there is an histotype, which is the fibrosarcoma and NTRK fusion related, that may have this kind of translocation, has this kind of translocation, and there are others of tissue sarcoma where this kind of mutation is very, very, very rare. The problem is when to propose to your patient to test the translocation of NTRK or not, because there is a problem of reimbursement and there is even a problem of the rarity of this kind of mutation. So sometimes it's very difficult even to propose to some patient to test if they are mutated or not, because we have problem of reimbursement. Sometimes patients have to pay for it, and you know that the possibility to have this kind of alteration is very low, and there is a not balance with the cost sometimes.
No, I agree. I think what happens at a specific institution, like the Marsden, with extra, funds available, is not a reflection of what happens in an entire country. But it is, I mean, because we have many clinical trials running, I think we're a bit privileged in terms of many aspects at the Marsden that we can test our patients, especially if they're progressing on standard lines of treatment, and as I said, not only sarcoma but with other cancers as well, we do.
I think all day today we've had discussions around clinical trials and the challenge across the world, that things are not equal, and we can't always just take some of the pieces that we're hearing and it can be applied, universally. It's obviously a very complex situation, and understanding the specifics within the country, reimbursement issues. I mean, you have to be an expert in everything, right? Not only understanding disease, but how will this impact? Because, and I think patients appreciate knowing that you're being thoughtful about that, so that you're not left with these high expenses, and because we know that can be a burden as well. So, do we have any other questions from the audience? Really want to thank you for your hard work in the area of soft tissue sarcoma and continuing to pursue. Many people today are still facing challenges, and we know, unfortunately, there'll be people tomorrow that will be diagnosed and are going to be needing the hard work that you are all doing, and we really, truly appreciate you coming today and giving us the updates, and for your hard work in trying to find better therapies and approaches and better understanding of these really complex diseases. So thank you all very much. I think now we have a bit of a coffee break until 4 o'clock. Okay.